Here we have Teresa Girolamo. Thank you.
Thank you, Kimberly, and thank you, Helen. That was very powerful, and I guess we see that in the primary care setting. So I'm going to primarily talk about addressing inequity in the primary care and the challenges we face in doing this. And I think primary care is and should continue to be the backbone of our healthcare system. I'm a general practitioner and I work solely now in weight management and metabolic health, just as a bit of background to me. So next slide, please. So I guess the first issue is actually identifying the problem and starting that conversation in the primary care setting. And we know, unfortunately, even though 2/3 of our population live with either overweight or obesity, in the primary care setting, only just over 22% of patients have a BMI recorded, and just over 4% have a waist circumference. And we know from the new Lancet Commission that we need to be measuring both of these parameters. In addition to that...
Teresa, sorry, can I just get you to speak a little bit closer into the microphone? It's just a bit hard to hear you.
Absolutely. Sorry about that. Can you hear me better now?
Yeah, a little bit. Just very quiet.
Better? Okay, sorry about that. So less than 1% of GP consults centre around obesity, and so we need to change this. And we know that it's an average of 9 years between the time that an individual first struggles with their weight and when they first discuss it with their healthcare provider. And so what, I guess, are the barriers and challenges that we face here? Next slide, please. So we've already heard beautifully about the issues of weight stigma and weight bias, and unfortunately we as healthcare providers are amongst the biggest offenders in this area. And this can absolutely negatively impact patients' wellbeing and engagement with the healthcare system. Education is another big issue, particularly with general practitioners and primary healthcare providers. They need to understand the complexities of obesity and managing patients living with obesity. We need to have the education, the adequate training, adequate resources and referral pathways. Then we come to funding models. We know that Medicare provides inadequate remuneration for relevant service provision, given the complexity of care, of chronic health in general. And whilst I'm not political, we know that the bipartisan agreement of universal bulk billing, this will only provide us with greater challenges in the management of patients living with complex conditions, including obesity. And unfortunately, it fosters that rapid throughput of 6-minute medicine, and we cannot manage a patient adequately in this time frame. Clinic equipment and setup, we need to make sure we have appropriately rated seating, accessible areas in our clinics, the larger size blood pressure cuffs, bariatric scales. They're just amongst some of the equipment that is required so we don't perpetuate the stigma when patients come to see us. Then, of course, we've got interdisciplinary care, and we need to make sure we break down the silos and start working with a team. We need to find our tribe in our local area who are, individuals who are also interested and have the knowledge, the adequate knowledge to manage patients living with overweight or obesity. The cost of treatment. So we're very fortunate now that we have some very effective treatments, both pharmacotherapy and, of course, bariatric surgery are two of some of the more advanced management strategies. Of course, we know that diet and exercise is the cornerstone to any program, but we do have other options, and some patients will have difficulty either losing weight or maintaining weight loss. Unfortunately, there's a great cost that comes with these treatments, and that just further challenges the inequity in the system. And then, of course, we've got the vulnerable communities, and we've already had some information about the challenges here. So remote communities, and we saw I think from one of Tim's slides, the great disparity in the prevalence of obesity in certain communities. And Indigenous, culturally and linguistically diverse, and the disability sector. And we know that there is higher incidence of obesity and less access to care. And then, of course, the cost of treatments exacerbate these existing societal inequities. So thank you.